Patient Safety and Quality Clinical Excellence Queensland has developed a podcast series for Queensland Health staff and Hospital and Health Board members to hear from guest speakers on topics relevant to safety and quality in short bite-sized segments. All episodes are recorded on the lands of the Yagara and Turrbal people. We respectfully acknowledge them as the traditional custodians of Meanjin and pay respects to the elders past, present and emerging.
Hello and welcome to the second episode of a two-podcast series on Hospital and Health Board Safety and Quality Committees. In the first episode, we discussed the construct of these committees and the overarching approach to how they work. In this episode, we'll focus on the functions of a Hospital and Health Board Safety and Quality Committee. I'm Kirstine Sketcher-Baker, the Executive Director of Patient Safety and Quality, and joining me today from the Metro South Hospital and Health Board Safety and Quality Committee, Associate Professor Helen Benham and Matthew Ames. Hello to you both.
Hello again.
Hello. Our Safety and Quality Committee is legislatively responsible for advising the board on matters relating to safety and quality of the health service, with the Hospital and Health Boards Act specifically identifying minimising preventable harm, reducing unjustified variation in clinical care, improving experience for patients and carers, and complying with national and state strategies, policies and standards. Matthew, what information does the Safety and Quality Committee consider to assess the health service is minimising patient harm?
Thank you, Kirstine. I think the predominant measure that comes through in relation to patient harm with the health service we see through the clinical incidents that we receive. And they are predominantly provided through the severity levels of those incidents so that we can actually look at them based on the harm that actually occurred within the health service. And I think one of the things that is really important when we look at those in relation to function of the committee is actually asking that question of how do we prevent these things from occurring within the health service. And for me, that really goes to what can we learn from those incidents. And depending on the severity, different things occur, and so we learn in different ways is probably a summary. So the higher level incidents, it's really about investigating the individual incidents, or if there are clusters of incidents, actually looking at those. And they obviously get quite a lot of attention through investigations, and then really asking ourselves, how do we actually prevent not only those from happening, but how do we learn as much as we possibly can from things that may have gone wrong and prevent things from going wrong again in the future. And I think creating an environment where we're really focusing on learning rather than blaming, I think is really important because I think that creates an environment where we're much more likely to be open and honest and actually learn as much as we possibly can from these particular incidents. Then particularly a large health service like the one that we look after, there's probably more volume as you go to the next levels down. So for those, it is not only looking at them individually at a operational level, but at a governance level, it's actually looking for trends and clusters, and again asking ourselves, what are the things that might be leading to improvement? How can we learn from those, and what can we do better? And that's quite tough because we get a lot of data. But when you actually aggregate up into an overarching system level, you're actually trying to identify causal factors that are in the context of the complexity of healthcare is quite a struggle and quite challenging. So we can do that through various different ways. We can rely on either the data itself or we can actually convene groups to actually look at things, or people to actually investigate groups of things and go to those people who actually understand the incidents to actually get those learning. So it's a multifaceted approach to really look at minimising preventable harm. So that's probably the predominant mechanism, and I think there are other things that we need to look at in relation to either external bodies that may be looking at things from the health ombudsman or the coronial matters or legal claims. So I think there are other data points which we need to make sure we keep an eye on. Again, from an overarching goal of learning as much as we possibly can from these.
That's good. Thanks, Matthew. So it's about really identifying for those individuals who've had that significant harm of death or permanent harm ensuring those have been investigated well, ensuring that there's been the appropriate follow-up. It's really looking at trends across the health service to identify where there might be themes to really drill down into and follow up and have those lessons learned.
It is, and I think the other thing is actually, as the health services have got better at things like open disclosure, is actually how we're going on that, and how we're actually making sure that we engage the consumers who are impacted and look after them through the process, as well as how do we look after our staff through that process, because it can be a hard thing to do, and actually just reinforcing that piece of learning as much as we can and preventing things from happening again.
Thanks, Matthew. The second area is around unjustified variation. Helen, what on earth does unjustified variation mean, and how do we actually look at that as a Safety and Quality Committee?
Sure. So, look, in clinical care, variation is in itself not necessarily bad. And so that variation might actually just reflect the health service itself, the population which it is serving, or particular delivery of clinical care in that place. But it's when there is a difference in clinical outcomes in a health service that doesn't reflect those sort of factors that we think that that's unjustified variation. And the way we try and look at that, there's lots of different ways to have a look at that. One of the examples are VLAD indicators, and VLAD's just a screening tool really that's applied to clinical variation, which allows you to apply some pre-specified level of variation, which then allows you to put a flag against something. And so that flag then, like the name suggests, can draw your attention to what might be a level of unjustified variation. And then hopefully what you're able to do is also see a trend in time to see if that variation is momentary or across a longer period of time, and might also geographically in a large health service, as an example, allow you to see that variation at a hospital level or a department level or otherwise. And so those flags then allow you to ask questions of that variation and really drill down into the causes for that, and they may very well be justified. And if they're not, then taking the necessary steps to reverse that level of unwanted variation, essentially. We can also use, as Matthew's already mentioned, external reports as a way of identification, and I guess benchmarking has a very big place in looking for variation of care. And so benchmarking across within the health service itself is possible, across departments, across hospitals, and then across different HHSs within Queensland, nationally and internationally. And you might use particular reports or data that allow you to establish if there is variation in our particular health service related to that external data. And one of the other ways that we look for unwanted variation or otherwise is in the rates at which things might happen. So you can consider that in surgery as an example. So how often do we intervene with a surgical procedure for knee osteoarthritis as an example? And how does that compare in between our hospitals, and how does that compare in between our health services? And in fact, how does that compare to a nationally accepted rate and perhaps an internationally accepted rate? So they're the sorts of, I guess, unwanted variation really is unjustified variation. The most important piece of that, of understanding that, is having a reference point, if at all possible. And so that's how we try and look for unwanted variation in clinical care.
That's great, Helen. And I would envisage that a health service would provide the board with a range of different indicator results, and they would indicate if there is some sort of a flag, or if there's an indicator that has a higher rate than what we would anticipate. But importantly, they would provide the information as to the why, so that you could have a look to see whether that variation is warranted or not. And then would they provide actions around that sort of thing?
Yeah, so there might be different levels of action required or thought to be required. The first level of action might be to return with further information and really drill down into a particular variation and return with a report, which, might seem to be necessarily more urgent or semi-urgent or not. And then there'll be a further examination of that information. And sometimes we might ask for, as I said, that external view on what that might look like via the flag. And then the most important thing about looking at data is not just looking at it, right? It's deciding what needs to be done based on that. And so there will be often a series of recommendations that the health service will bring to us in response to variation. And then the most important thing is to then monitor and have a feedback mechanism within your safety and quality committee to see the evidence that those actions have been carried out and that there is a resultant change in that unwanted variation.
Great, thanks for that. Now, moving on to the third area, it's all about improving patient experience and carer experience. Matthew, how do we know as a Safety and Quality Committee the experience of patients and carers?
Well, probably one of the key measures, and there's a few within that is available to the health service, is the experience measures, patient-reported experience measures for the health service. And for those who aren't aware, I think if you turn up, you get a SMS and then get some feedback, sort of usual survey. And that particular data is regularly reported, and I think again, and it's benchmarked, similar to what Helen was mentioned before. So you can see where there are variations, both positive, negative, and otherwise, through lots of different questions. So that's one way that we can get feedback on how we're going as a health service. It would be nice to get the response rate a bit higher, but I think that's something that we kind of need to look at as a system. But that's been going for quite a while now, the patient experience surveys. So that's one measure. And again, similar to the variation conversation that Helen had, it's actually about understanding why. And then what can we do to actually improve in those areas where we may not be meeting the needs of our consumers, patients and consumers. So I think the other measures that we look at, compliments and complaints, it's good to know what's going well as what's not going well. And probably the key areas that we get in relation to complaints in particular, and also compliments, is obviously is access and treatment. Are probably the two key ones that consistently come through. And I think we're now at a stage where we really need to go to a deeper understanding of those. Access, we know access is challenging, and we've probably got a good handle on where our access issues are. It's probably the treatment space and actually unpacking that a little bit more, and understanding what are the key factors driving that, because it's good to know the data, but it's difficult with the systems to actually really understand what are the themes underneath that. And so, similar to the other variation measures, it's actually doing some more work on understanding those. So I know our health services is looking in how we do that at the moment. It's not easy, but we need to find out. And that also correlates to some of the other things that we look at in relation to, for example, Ryan's Rule, I think, is an indicator where things have not gone the way the patients or the family or consumers have actually wanted. And sometimes that is related to a treatment pathway, but quite often it's down to things like communication and engagement with the patient or the family. So again, that's another opportunity to learn and improve through those. And I think it's also important to listen to the community. There may be other things. I think all of us as board members have been approached by people who may not have had the best experiences or have had really great experiences. So I think as a board, how do we actually listen to our community, and how do we actually do that in a way that respects our role, respects the executive, but also gathers that information that we can then get an understanding of how the community perceives our service. Because I think one of our key roles is ensuring that we have public confidence in the service that we provide, and if we lose that, then that's something that's going to significantly impact on us. So they're probably the key things that we would look at within the committee.
That's great. And Matthew, in terms of, from time to time as a board member, you may have people approach you to express concerns or a complaint. What do you do with that information? How do you know if that is a significant issue within the health service, or is it just a one-off? How do you reconcile that?
Yeah, for me, it probably depends on the level of severity or risk of the thing that's being brought to me. Obviously, I think the important thing as a board member is to listen, because it's part of our community giving us feedback, and then getting the context around that. So, and listening to the context from both sides. So, for example, it might be about something we may not have done particularly well. The health service may have a context and an understanding, but that may be quite different to the context and understanding that the community member might have. And it's actually, before you do anything, actually gather the context from both, so that you can then work out what the best pathway forward might be. But remembering that it's for the health service to resolve, and as board members, our role is to make sure that actually happens. So I think getting that context from both sides first is really important, and then working out with the health service executives what the best way forward is, and then trying to bring the parties together, because I think it's important that the health service develops and improves any relationships that might have broken down with those particular individual members.
That's great, thank you. The next area is around compliance with national and state strategies, policies and standards. So how do you do that in terms of safety and quality committees, Helen?
So there's actually a number of ways that compliance is measured and monitored by safety and quality committees. And the Safety and Quality Committee is really integral to that on behalf of the full board. And so all hospital and health services are accredited according to the National Safety and Quality Healthcare Standards. And so there are a number of those standards, and hospitals and health services will undergo accreditation related to those standards. So across the health service, those standards will be attended to by a number of subcommittees, both from a governance and an operational point of view. And it's important to have a system whereby all of that feeds back to safety and quality. And that sounds very simple, but of course it's actually quite complex and complicated, and there is a lot to look at. And so it's not for the Safety and Quality Board Committee to review every piece of operational activity in the health service. So there needs to be a system in place with an appropriate governance, so that what does come to the committee is at that higher order level, but with enough detail to allow board members to drill down where it might be necessary. Aside from the standards themselves, there are, of course, a raft of Queensland health policies. There are health service directives from time to time. There are strategic policies and guidelines across the health service itself and within hospitals. For example, there would be consumer and community engagement strategies. There's clinician engagement strategies. And so the implementation of these strategies in how they relate to the delivery of safe and quality care is the business of the Safety and Quality Committee. And so having mechanisms within your agenda, within the people that you invite, within the structures below the committee, that all needs to come back in a way that can be reviewed, essentially. And then I guess it's really important just to ensure that the presentations and the papers that we receive from various parts of the health service all speak in a uniform way to the compliance that we're charged with as board members of a health service.
And Helen, in terms of accreditation, so if your health service is accredited yesterday saying, yes, you've received accreditation, does that mean that the health service is safe everywhere?
So accreditation is a vehicle for a minimum level of acceptable doing business, if you like, in a healthcare environment. In fact, what we do know, of course, is that we need to be striving well and above an accreditation level to make sure that we're delivering a high quality and safe environment for everybody that comes into that environment. And so I think accreditation, whilst very important from a compliance point of view and necessary to a well-functioning, health service. It's a minimum level standard. And we know that it's important to ensure that there are a whole variety of other activities going on in improvement and quality care and otherwise that don't necessarily speak directly to accreditation.
Thank you. So good leadership, open communication, mutual respect, shared goals, and a commitment to employee growth and development all contribute to a good workplace culture, which we were talking about in our earlier podcast. Importantly, though, we know that in the literature, workplace culture of services can be a very strong predictor of safety and quality of care delivered. And in acknowledgement of this, we recently added to the Hospital and Health Board's regulation a requirement for committees to monitor workplace culture of services in relation to the services provided. Matthew, how does the Board Safety and Quality Committee monitor workplace culture?
Thanks, Kirstine. I was actually really pleased to see the legislation change because I think that's probably a core function of the board and the Safety and Quality Committee is to really have a line of sight and oversight of that culture and where we're at. I think one of the challenges historically within safety and quality is due to the very large compliance burden that does exist within this particular environment. There has been a propensity to need to focus on that. So I think that has been changing over a number of different years. And I know we as a health service have been really looking at how we can do this in better ways going forward. So probably the traditional way of saying let's monitor culture will be let's do a culture survey, and there's been a number of those over a number of different years, and I think there's still some open questions as to system wide across Queensland. How do we best do that? I know you're aware of. So we have been doing those, and we changed survey get a little bit more detail on the culture within the particular health service. But I think it's a misnomer to just rely on those. There are so many other things that we can actually look at to have oversight and monitor culture and see that and how it actually is performing. So in addition to those, I'll just stay on that culture surveys for a little bit because I think particularly in health services, there can be quite a lot of different pockets of culture, as in any organisation. So, I think it's can be a bit of a misnomer just to focus on the headline number and say we're okay from a culture perspective. I think it's actually understanding almost down to a work unit level. Do we have areas where there may be issues within the culture survey, but there are lots of other pointers to that. Be it a lot of the people and culture information. You may be getting bullying in certain instances, or you may be getting workplace behaviours that may not be appropriate, and that will give you an indication of your culture. You also may be getting more complaints or things raised within the patient reported experience measures that I was talking about that may indicate at a work unit level you might have some difficulties, and there may be more incidents in particular areas. So I think as we go from a culture perspective, from a monitoring perspective, I think it's actually important to look at all of the different indicators and step back and go, do we have a particular issue in any particular parts of the organisation that we need to look at? And one of the things that our health services is really trying to implement is triangulation of that data to actually look at a particular areas within the health service from multiple perspectives to see if there are trends or things that we need to improve. So as far as monitoring culture, I think it's really important just to keep on that. And also, there's nothing better than actually seeing a service to actually understand and hear from people, and that's employees or patients as to how things are going. So how do we as boards be visible enough without interfering and getting in the way of the day-to-day business is something that I think all boards need to work on. And it's not easy, but I think I always appreciate actually getting to hear from people on the ground level. So I think the other thing, in addition to trying to find areas where we need to improve, and once we do find those through whatever mechanisms we do, is actually making sure that we actually have decent plans in place to actually support the people and not just tell them to get better. How do we actually support people in those areas to improve and the culture within those parts of the health service. And I think the other really important thing is searching out and finding those units that are doing really well, celebrating those, learning from them about why, what are they doing well that we can actually learn and apply to others, and ensuring that we actually focus on the really good as well as learning and improving on those where we actually need to improve. So yes, culture, I could talk for hours, but they're probably the key things that at a safety and quality board level we would focus on. Helen, is there anything else in relation to culture that? So I know it's a passion of yours as well.
I just think, just reiterating that it is a really important part of the safety and quality agenda because it contributes to the safety of our patients in so many different ways. So it is our business. It's legislated to be our business now, but of course it really is in everyone's, the whole entire health services interest that we understand culture and that we attend to parts of that culture where we might need to.
And I think the improvement piece, and I think that constant creating that environment of learning and improvement from a cultural perspective, and I think that is tough because of the focus on the compliance. So to a certain degree, if we can get to a point where the compliance piece is really operational on with the health service, we can then focus much more on that continual improvement, and that also applies to us as a board. Where can we improve? Where do we need to upskill ourselves? Ensuring we get feedback from various stakeholders, and including the executive on things that we may not be doing that may not be adding value, and also external parties on how we can do better. So that constant drive for improvement should apply to ourselves as the board as well as the health service, because the health service doesn't always get it right and we don't always get it right, but I think the important thing is being open, recognising those things, and always striving to get better.
And Matthew, I think that leads well into the next question around, in the legislation there is a lot of focus on assurance. We've talked a lot about assurance, but importantly, there is that aspect of improvement. So how do you know, Helen, in terms of within the health service, what sort of improvements are at play? How do you actually promote that within the health service?
So I think this is, and Matthew's already touched on the importance of an improvement culture. And so that can't be just within the Safety and Quality Committee. That needs to be a focus for the full board and the entire organisation, essentially. But the ways in which you can try and understand the improvement activity that's across the health service, there's a variety of ways to do that. And they might include quality improvement projects and outcomes. They might include various research programs that are embedded across the health service, or in fact across the entirety of Queensland Health, or more national programs, audits. Clinical registries, we have a number of large clinical registries which sit within our health service that may very well be linked to more broadly state and national level registries which provide data on improvement activities. We can look at, in quality and safety specifically, various topics, that speak to improvement, and they might be around particular areas. For example, we might look at inter-hospital transfers, we might look at morbidity and mortality meetings, we might look at cardiac outcomes, thoracic outcomes, and I'm just using these all as examples as to how functionally within a safety and quality committee you might look to see what improvement activities are being undertaken, and then importantly, encourage that improvement activity to be spread across the health service. So and indeed the entirety of Queensland Health, because of course we know there might be great improvement activities occurring in one health service that can be easily translated to others. So there is a communication piece here for us as board members and safety and quality committee members to make sure that we are talking with our colleagues outside of our individual health services. And that I really think it's important that Queensland Health plays a role to ensure that particularly improvement activities, whether they're of a quality nature, research nature or otherwise, are in forums really that exemplars are discussed to ensure that there really is that culture and the ability to implement across different health services and as well. So there's lots of practical ways to look for and encourage improvement across health services. And we're always looking to ways to actually do that better, is what I would say.
Thanks so much, Helen and Matthew. Really appreciate your time today. You've helped us in understanding the functions and what that practically looks like for our Hospital and Health Board Safety and Quality Committee. Thanks again.
Our pleasure.
Thank you.
Further information regarding Hospital and Health Board Safety and Quality Committees can be found online at the Queensland Health website. Thanks for listening.